Dear Chairman, dear professors, I would like to thank you for your kind invitation and thank, of course, Genesis Pharma for giving me the chance to participate in this very interesting webinar. Genesis Pharma is, as we know, one of innovators in Greek territory, and with this webinar, I think its activity expands our traditional borders. Our intention will be to show how the real-world evidence agrees with the issues and the items that Dr. Stamatelou mentioned just before. Without any delay, we start with the VERIFY, which is a non-interventional prospective multicenter cohort study. 7 countries of Europe participate in this study, Greece included, with Laiko Hospital. And for a study period of approximately 42 months, the authors tried to find out if the sucroferric oxyhydroxide is safe and effective in dialysis patients with hyperphosphatemia, and of course to address how safe is this drug in our everyday clinical practice. Seems that diarrhea is the most common, let's say, adverse effect, which seems to be to be visualized to our patients in the first 2 to 3 weeks. It seems to be mild, and in the most of the cases, it's self-resolved. Also, discolored faces it was another item that was also noticed. The fact that was mainly addressed is that the phosphate levels significantly reduced for this study period from 6.3 to 5.4. And if we want to investigate further in the subgroup of patients that achieved phosphate levels below 4.5, it seems that we have a great portion of them, approximately 31% until the end of the study periods, that achieved this very healthy, let's say, level for our dialysis patients. And we carry on with. There is the retrospective analysis, the Euclid, which also came from Europe in 6 countries, and also try to evaluate, sorry, the real-world effectiveness of sucroferric oxyhydroxide for controlling phosphate in European hemodialysis patients for a time period of 1 year. We also noticed that we had significant reductions in phosphate levels during the study periods, and we also had a significant proportion of our patients achieve phosphate levels below 4.5. But the bottom line is that we had these very good results in the real world field with much more less pills and with any adjunction or any combination, and approximately we had significant reduction, nearly to half of the number of pills that we start with. Regarding the iron deficiency, and let's keep in mind this tool, we had significant impact on that, and specifically we had a slight increase in ferritin levels, slight increase in chat levels, and the stabilization and slight increase in hemoglobin levels. Let's go to the real world evidence from the States. We have this study from Kendrick from 2019, which was tried to examine the long-term real world effectiveness of sucroferric oxyhydroxide in managing phosphate levels in hemodialysis patients for 1 year period in Fresenius units, along with data regarding the safety levels and the mean number of pills that used per day. So the impressive thing is that we had significant improvement in phosphate management from the switching of the 3 previous medications that had been used in this dialysis population. And this improvement came with a significant reduction to the mean pills that were used every day, nearly to half. And as we see in this graph, the significant impact of the levels in phosphate levels below 5.5 was impressive. Also, we had a significant impact in the nutritional parameters in our patients in this study, and we carry on with a Gray and the colleague study from 2019, who assesses also the impact of conversion to sucroferric oxyhydroxide from another regimen, and to see retrospectively how this came along with effectiveness and safety for a period that appeared to be roughly 6 months. So we had a significant reduction in the number of pills, nearly to half. But the most interesting point, from my point of view, is that we prescribed the regimen and our patient actually received it, which means that we had very good compliance regarding the prescription that was followed by the dialysis population, which seems to be the result of the significant declined number of pills that has been used. And of course, we had significant increase, roughly 30% in our patient that achieved phosphate levels below 5.5. And we carry on with this study from 2020 for a period of 2 years, retrospectively analyzed the Fresenius data from the dialysis unit with the same goals, in order to find out how sucroferric oxyhydroxide is safe and efficient, which seems to be the story. And actually, the impressive thing is that we had the same and even better outcome, actually with very small number of pills, and actually with a stabilization of the phosphate levels below 5.5. And also, we see that we have this goal with a significant reduced number of pills from 8 to 5, roughly 50%, which is not the case with the other regimens that had been used. This also changed in their patients, in our patient medication, had significant impact on the hospitalization, which means better quality of life for this dialysis population. Our team started to collect data regarding the use of sucroferric oxyhydroxide and start to expose this data since the RWE in Spain 2017, then to Copenhagen 2018, and ended up with this publication 2 years ago. We studied a small amount of patients, 31, which were stable, and that was because we wanted to examine and investigate how in this normal and acceptable population in dialysis, this new regimen for us was sufficient and safe enough. And we started with titration of the dose, as Dr. Stamatel mentioned before, starting with 1 pill per day to see how things went, and then we gradually increased our everyday medication to 3 to 4 pills, with average recipe between 1 to 3 pills per day. We started this study and investigate our patient for 10 months, and we tried to compare the phosphate levels with other parameters, just as nutrition, anemia, lipids, other biomarkers of metabolic bone disease, and to see how things can be changed with one change in our medication for phosphate. And we also noticed a significant reduction of phosphate levels, even from the first month of our treatment, from 6.5 to 5, approximately 23 reduction from the baseline. And this trend carried out until the end of this 10-month period of our study protocol, with phosphate levels roughly 4, which means 38 reduction from the baseline. And thing that was remarkable from our point of view was the reduction of PTH levels. And that happened in our study population population without any change in vitamin D or calcium supplementation after 6 months of therapy with sucroferric oxyhydroxide. And we actually saw that PTH levels started with 698 at the beginning and ended up to be 433. Ferritin levels remained rather stable with mildly increased but not significant, and the hemoglobin levels were also stable. Nutrition parameters, cholesterol levels, and calcium levels had an remarkable difference. So the bottom line is that in our study population, we also noticed a significant reduction of PTH apart from the phosphate level, which remained the same until the end of our notice period. It seems that persistent hyperphosphatemia, as we know, is a very common thing along with the severe high PTH level. So the above fact makes them receive a very big list of medication, and a lot of things have been discussed and addressed this evening regarding drug-drug interactions. And we honestly know that we don't know how our drugs interact each other. So the therapeutic activity of each one is in question in many cases. So, as Dr. Stamatelou mentioned in her previous presentation, Sprague has showed that we have interaction between phosphate binders with oral video arrays, especially with sevelamer, which is not the case in our study with sucroferric oxyhydroxide. And I think this would be a very good explanation for the reduction of PTH level in our small study population. Another issue is that there are published data that show that the reduction in FGF23 due to reduction of serum phosphorus provide a very good explanation for the reduction of PTH. It seems that the transcription of FGF23 has been reported to be enhanced by iron deficiency, but not directly by serum phosphorus, serum calcium, or Richter PTH. So I think that our small paper demonstrated that the sucroferric oxyhydroxide is a tool that could be very helpful in other aspects of CKD MPD, which is also the case in this oral presentation in the last Kidney Week, a month ago, which shows that iron-based phosphate binders has a major role controlling high serum phosphate and, let's say, controlling iron deficiency anemia in regards on FGF23 levels. It seems that the combination of iron-based phosphate binders, the combination of its substitutes, makes a significant impact of FGF23, which is a major factor that contributes to the production of inflammation and fibrosis in kidney disease. To end my presentation, I would add these two papers, two posters that have been showed also in the Kidney Week a month ago. This is also from the Fresenius dialysis units, which confirms that we have significant decrease in dialysis population with the use of sucroferric oxyhydroxide, with the safety with a safety profile with a very small number of pills. And also another poster from the Kidney Week a month ago, which shows that sucroferric oxyhydroxide has also a very favorable impact in phosphate levels in peritoneal dialysis patients in the Fresenius Kidney Care team. So, to sum up with this briefly review of the published data, I would say that consistent to the results of this study, sucroferric oxyhydroxide offers effectively controlled phosphate with a few tablets, on an average of 3 to 4 per day. Also seems to be a reliable choice in patients with unregulated phosphate levels, which undergo other hemodialysis or peritoneal dialysis. It seems that the change of treatment from another phosphate binder to sucroferric oxyhydroxide significantly increases the percentage of patients achieving the phosphate targets while reducing significantly the tablet load that our patients are used to take for phosphate control. Thank you very much for your attention.
Thank you very much, Dr. Griveas. We'll continue with Dr. Premuzic, and we'll have the